austerity plus oversight, it becomes the objective itself. Well, it is, I think this is a risk also in Spain, even though we don't have the Merkel, the Troika in the country. I think it is a risk here also, okay? And we assume that risk by reducing linearly. So by reducing, okay, 10%, every hospital in the country has to reduce 10% of the budget. Okay, that is bullshit, okay? That is not worth it at all. And somehow we are assuming that the budget constraint is the objective. Somehow, yeah, I think we are in the same risk. And what else? Well, it is easier to do things that can be done by law, just with regulation. That is very easy. It is quite more difficult when you deal with persons, when you deal with organizations, with human behavior, with interactions between, and you have experienced that in Portugal, and I think it's the same. It's our main challenge in this country also. So I think we have many things in common with Portugal, and somehow you have some advantage over us because you started before. Well,
I know that's really an advantage, but okay.
Okay, so we have now some time for questions. We have two questions here. Professor Laveaga.
One question for each. From Bea, I infer, I don't know, I have understood correctly what you have said, but I infer that we were living well above our possibilities. And in some moment of the time, some guy came, very, very famous guy came and say, the feast is over. I don't know whether it's true, because when you look at a number of visits or number of prescriptions of drugs or things like that, I think that we were living in this state. And the question for Pedro is, even with the memorandum, you can see that nothing related to human resources has moved. Or if it has moved, it is very slow and very... So the thing is, why this is happening in Portugal? Is it something related to the institutional setting, the political fear, the economic? I mean, whether the civil servants or the medical unions have a lot of power or something like that. I don't know whether it's behind. Because the other measures are very easy to implement. And even without a lot of political cost, because it consists of moving a tax or introducing a regulation, which come from another part of the continent. But the other things are really related to the country.
Okay. Jose Maria, honestly, I don't know. But well, Spain has a record in the number of prescriptions per population and in the number of medical visits, and so a decreasing in those indicators by itself is not necessarily bad, okay? But the question is that we should know. We should know who is reducing, who is using the services and for what, and what is the result in terms of the outcomes in terms of health. So that is the worry, okay? That is the worry, because traditionally the Spanish health system was qualified as more equitable than efficient, okay? And I don't know, but maybe because there is no cap in the co-payment of non-pensioners in Spain, maybe what is happening is that a small fraction of the population is paying a very huge percentage of the total co-payment. And that could be a problem of inappropriate use or lack of use of health services, and a problem of equity also. So.
Okay, very quickly again. Well, I could comment on living above the possibilities as well, since we had this discussion in Portugal for a long time, but that will take me an hour. But basically, I think that's totally a speech, kind of discourse that is basically trying to fool people, but that is another matter. Now, about human resources in Portugal, why nothing is moved. It's not true that nothing has totally moved. As I told, there was this agreement that was actually, which I think is an important piece if they are going to implement it, which is still to see. Because, of course, if the doctors are seeing more people, they will also have to have some payment difference on this thing. So it's still to be seen how it goes. But why didn't move more in the other areas? Well, there's different problems. One of the problems is the distribution of doctors across Portugal. Portugal does not have few doctors. It has them misplaced, regionally and in specialities. And the question is, how can you move people from one place to the other? And that's, I think, where people don't have a clue of how to do it. They cannot use money, but they are not clever enough to see how they can try to convince health professionals, in particular doctors, to change from where they are. And for example, I've seen in the center of Portugal, there is one area that wants to attract some physicians there, and they didn't yet understand that what will attract them is not paying more, but it's giving a project for life, giving an interesting job, giving opportunities to do what they like. Mm-hmm. And that is not thinking about giving a wage bonus for 3 years. That's not what they are looking for. And I think there is lack of creativity in finding the right instruments that will drive people. And I think that's the basic reason why they didn't move to a certain extent. Then you have the institutions, in particular professional associations, that try to fight on things that they're not that important. One of those areas is between nurses and doctors. The idea of family nurse that has been ventilated in Portugal for several years now is still under discussion. And the idea is basically very simple, is that say that maybe nurses can prescribe from a set formulary, and maybe nurses can follow pregnant women, maybe nurses can follow chronic conditions of patients at home. Why does it not happen? Why we see this existing in other countries? One of the reasons is because the Medical Association and the Nurse Association discuss a lot whether, for example, prescribing is done under direction of a doctor, under the supervision of a doctor, or whether it is autonomous prescribing. And while they are fighting on the words of what it means being autonomous exercise of prescribing, or it is supervised, they don't move. Because nurses don't want to be supervised by doctors, and doctors say they can only prescribe if they are supervised. Does it really matter that much? Can we find something different? I think that's where things get stuck. There is ways to move around it. Professional associations should probably move from having a precise definition of what they do, say, I prescribe so I'm a doctor and I can only prescribe if I am a doctor, to mission goals. Professional associations should have a mission, improve patient health. Doesn't matter how you get there. And I think that's some things that can be worked with governments on these directions. It's never going to be easy. You're going to deal with this ego stuff. Also associated with this ego stuff, you have economic rents, and you have to deal with them. And I think that basically we don't have enough skilled people in the government and negotiating these things to get things moving. That's my short answer on this.
Había una solicitud de palabra. Carlos Betancourt. Aquí delante. Este es un alumno mío.
Okay, first, thank you very much for the very nice speech. I just want to know your point of view regarding the effect, significant or not, of the emigration of the doctors to other latitudes, and whether or not this will affect the system. I want to know your point of view. Thank you.
Okay, let me start with another thing, okay? Let me start with something about nurses, because, well, we tried, also in Spain, we tried to give nurses an advanced role of prescribing, and that fails, okay? That failed. And we have another problem with that is our ratio between nurses and doctors is so low as compared with other countries, that really the nurse is the scarce resource in our system. And besides that, we have a very, very serious crisis of the primary healthcare, the family medicine in Spain. There are a lot of symptoms, of signs on that, okay? In the MIR, the residency program vacancies and so and so. Then, in this context, what happened in Spain is that a lot of doctors from Latin America, mainly, and some from Europe, but mainly from Latin America, came to fill the vacancies in the MIR specialization system that the Spaniards didn't want for them, because we had an imbalance between the number of new graduates from the medical schools and the number of residency positions, okay? And then, to have an idea of that phenomenon, in some years, at the end of the 2010, in Spain, the double of number, the number of foreign diplomas of medicine, homologados, approved, yeah, from abroad, was double that the number of graduates in the country. So that was a phenomenon very, very intense. What is happening now is the opposite, the other way around. So now the unemployment, short-term unemployment of Spanish doctors is increasing. Last month is 6,000 doctors in the unemployment list, and so some of them are going out and so migration of professionals is not a bad thing. It's a good thing in principle, okay? Unless they come from poor countries and that at the end are decapitalized, okay? But that is not a problem, I think, a main problem for us now.
El profesor Rodríguez Artalejo.
Thank you so much, Pedro and Beatriz, for this very interesting presentation. I have a question for each of you. The first question relates to this slide, to this survey. And I wonder if you have this data disaggregated by socioeconomic status, unemployment status, any measure to what extent the people has been suffering economically from the crisis. And second, if you also have disaggregated this information according to the sickness, the illness the individuals were suffering from. And as for Beatriz, I am very interested in the results on the suicide rates in Spain. I think that these results should be published as soon as possible, just to make everything, to let everyone to know that the crisis is not affecting the suicide rates in Spain. Far. But at the same time, there is some information that shows that the demand for mental health services is